This is Dr. Lyle Jones, Editor-in-Chief of Continuum. Thank you for listening to Continuum Audio. Be sure to visit the links in the episode notes for information about earning CME, subscribing to the journal, and exclusive access to interviews not featured on the podcast.
This is Dr. Gordon Smith with Continuum Audio. Today, I'm interviewing Dr. Teerin Liewluck, good friend of mine at the Mayo Clinic, about his article on the Limb-Girdle Muscular Dystrophies. This article appears in the October 2025 Continuum issue on muscle and neuromuscular junction disorders, a topic that is near and dear to my heart. Teerin, welcome to the podcast, and maybe you can introduce yourself to our listeners.
Thank you very much, Gordon. And I want to say hi to all the Continuum fans. So I'm Dr. Teerin Liewluck. I'm the professor of neurology at Mayo Clinic in Rochester, Minnesota. So my practice focuses on all aspects of muscle diseases, both acquired and genetic myopathies. Glad to be here.
I just had great pleasure of seeing you at a seminar in Houston where you talked about this topic. And so I'm really primed for this conversation, which I'm very excited about. I find this topic a little hard. I'm hoping I can learn more from you. And I wonder if, as we get started, recognizing many of our listeners are not in practices focused purely on muscle disease, maybe you can provide some context about why it's important for folks doing general neurology or even general neuromuscular medicine. Why do they need to know about this?
Yes, certainly. So I would say limb-girdle muscular dystrophy probably the most complex category or subgroup of muscle diseases because by itself, it includes 34 different subtypes and the number is still expanding. So by each subtype is very rare, but if you group together, it really have significant number of patients. And these patients present with proximal weakness, very high CK, and these are common patients that can show up in neurology clinic. So I think it's very important, even for general neurologists, to pick up what subtle clues that may lead to the diagnosis. Because if we're able to provide correct diagnosis for the patients, that's very important for patient management.
So I wonder if maybe we can talk a little bit about the phenotype, Teerin. I mean, your article does a great job of going over the great diversity. And, I think many of us here, limb-girdle muscular dystrophy, and we think of limb-girdle weakness, but the phenotypic spectrum is bananas, right? Rhabdomyolysis, limb-girdle, distal myopathy. I mean, when should our listeners suspect LGMD?
Yes, I think by the definition to all the LGMD patients, we have limb-girdle or proximal weakness and very high CK. So these are common phenotypes among 34 different subtypes, but if we dissect into details, they have some subtle differences. In the article, what I try to simplify all these different subtypes that we can categorize at least half of them into three main groups, that each group, the underlying defect sharing among those subtypes and also translate into similar muscles and extramuscular manifestations. You will learn that some of the limb-girdle muscular dystrophy may present with rhabdomyolysis, which we typically think of is as a metabolic myopathies. But if you have rhabdomyolysis patient, the CK remain elevated even after the acute episode, that the key that we need to think this could be LGMD. That's for that example.
So I wonder if maybe we can start there. I was going to go in a different direction, but this is a good transition. It's easy to see the opportunity to get confused between LGMD or, in that case, a metabolic myopathy or other acquired myopathies. And I think particularly adult neurologists are more accustomed to seeing acquired muscle disease. Are there particular clues that, or pearls that adult neurologists seeing patients with muscle disease can use to recognize when they should be thinking about LGMD given the diverse phenotype?
Yes. What I always tell the patient is that there are more than 100 different types of muscle diseases, but we can easily divide into groups, acquired and genetic or hereditary. So the acquired disease is when you encounter the patients who present with acute or subacute cause of the weakness, relatively rapidly progressive. But on the opposite, if you encounter the patient who present with much more slowly progressive cause of weakness over several months or years, you may need to think about genetic disease of the muscle with also including limb-girdle muscular dystrophy. The detailed exam should be able to distinguish between each type of muscular dystrophy. For example, if proximal weakness, certainly limb-girdle muscular dystrophy. If patient have facial weakness, scapular winking, so you will think about facial scapular immunodystrophy. So the slowly progressive cause of weakness, proximal pattern of weakness, CK elevation should be the point when you think about LGMD.
So I have a question about diagnostic evaluation. I had a meeting with one of my colleagues, FAAN, who's a great peripheral nerve expert who also does neuromuscular pathology. And we were talking about how pathology field has changed so much over the last 10 years, and we're doing obviously fewer muscle biopsies. Our way of diagnosing them has changed a lot with the evolution of genetic testing. What's your diagnostic approach? Do you go right to genetic testing? Do you do targeted testing based on phenotype? What words of wisdom do you have there?
Yes. So I mean, being muscle pathologist myself, it's really sad to say that the utility of muscle biopsies when you encounter patients with suspects like limb-girdle muscular dystrophy have reduced over the year. For example, we used to have like 15, 1,700 muscle biopsies a year. Now we do only 1,300 biopsies a year. Yes, as you pointed out, the first step in my practice, if I suspect LGMD, is to go with genetic testing. And I would prefer the large gene panel that not only include the LGMD, but also include all other genetic muscle disease, as well as the congenital myotonic syndrome, because the phenotype can be somehow difficult to distinguish in certain patients.
So, do you ever get a muscle biopsy, Teerin? I mean, you obviously do. Only 1,300. Holy cow, that's a lot. So, let me reframe my question. When do you get a muscle biopsy in these patients?
Muscle biopsy still have its place in LGMD patients. It just, we don't use it as the first tier diagnostic test anymore. So we typically do it in selected cases after the genetic testing in those that it came back inconclusive. As you know, you may run into the variant of unknown significance. You may use the muscle biopsy to see is there any histopathology or abnormal protein Western blot that may further support the pathogenicity of the VUS. So we still do it, but typically come after genetic testing and only in the selected cases that have inconclusive results or negative genetic testing.
I'd like to ask a question regarding serologic testing for autoantibodies. I'll refer to a really great case in your article. There are several of them, but this is a patient, a FKRP patient, who was originally thought to have dermatomyositis based on a low titer Me2 antibody. You guys figured out the correct diagnosis. We send a lot of antibody panels out. Wonder if you have any wisdom, pearls, pitfalls for how to interpret antibody tests in patients with chronic myopathies. We send a lot of them, and that's the sort of population where we need to be thinking about limb-girdle muscular dystrophies. It's a great case for those, which I hope is everyone who reads your article in detail. What do you have to say about that?
Yes, so myositis antibodies really revolutionized the field of muscle diseases. I recall when I finished my fellowship 13 years ago or so, we don't really have much muscle myositis antibodies to check, but now the panel is expanded. But again, the antibodies alone cannot lead to diagnosis. You need to go back to your clinical. You need to make sure the clinical antibodies findings are matched. For example, it's the key that if the myositis specific antibodies present only at the low positive titer, more often to be false positive. So you need to look carefully back in the patient, the clinical phenotype, and when in doubt, we need to do muscle biopsies. Now, on the opposite end, the other group of the antibodies, the one for necrotizing autoimmune myopathy, or the other name, immune-mediated necrotizing myopathy. This is the new group that we have learned only just recently that some patients may present as a typical presentation. I mean, we even thinking about necrotizing autoimmune myopathy, we think about those that present with subacute, rapidly progressive weakness, maybe has history of statin exposures. But we have some patients that present with very slowly progressive weakness like muscular dystrophies. So now in my practice, if I encounter a patient I suspect LGMD, in addition to do genetic testing for LGMD, I also test for necrotizing autoimmune myopathy antibodies at the same time. And we typically get antibody back within a week or two, but for genetic testing would take us a few months.
Yeah, and I guess maybe you could talk a little bit about pitfalls and interpretation of genetic tests, right? I think you have another case in your article, and I've certainly seen this, where a patient is misdiagnosed as having a genetic myopathy, LGMD, based on, let's say, just a misinterpretation of the genetic testing, right? So I think we need to think of it on both sides. And I like the fact that the clinical aspects of diagnosis really are first and foremost most important. But maybe you can talk about wisdom in terms of interpretation of the genetic panel.
Yes. So genetic testing, I think, is complex issue, particularly for interpretation. And if you're not familiar with this, probably best to have your colleagues in genetics that help looking at this together. So I think the common scenario we encounter is that in those dystrophies that are autosomal recessive, so we expect that the patient need to have two abnormal copies of the genes to cause the disease. And if patient has only one abnormal copy, they are just a carrier. And commonly we see patients refer to us as muscular dystrophy just by only having only one abnormal copy. If they are carrier, they should not have the weakness from that gene abnormality. So this would be the principle that we really need to adhere. And if you run into those cases, then maybe you need to broaden your differential diagnosis.
I want to go back to the clinical phenomenology, and I've got a admission to make to you, Teerin. I find it really hard to keep track of these disorders. 34 and climbing, a lot of overlap, and it's hard to remember them. I'm glad that I'm now going to have a Continuum article I can go to and look at the really great tables to sort things out. I'm curious whether you have all of these top of mind. Do you have to look at the table too? And how should people who are seeing these patients organize their thoughts about it? I mean, is it important that you memorize all 34 plus disorders? How can you group them? What's your overall approach to that?
I need to admit that I'm not memorized all 34 different subtypes. But I think what I try to do even in my real life practice is group it all together if you can. For example, I think the biggest group of these LGMD is what we call alpha histoglycanopathies. So it includes already 10 different subtypes of recessive LGMD. So alpha-dystroglycan is the core of the dystrophin-associated glycoprotein complex. It's heavy glycosylated protein. So defect in 10 different genes can affect the glycosylation or the process of adding sugar chain to this alpha-dystroglycan. They have similar feature in terms of the phenotype. They present with proximal weakness, calf pseudohypertrophy, very high CK. Some may have recurrent rhabdomyolysis, and cardiac and respiratory involvement are very common. This is one major group. Now, the second group is the Limb-Girdle Muscular Dystrophy due to defective membrane repair, which include two subtypes, is the different and allogramin 5. The common feature in this group is that the weakness can be asymmetric, and despite proximal weakness, they can have calf atrophy, and muscle biopsy, sometimes you can see amyloid on the muscle tissues. And the third group is the sarcoglycanopathy, which includes 4 different subtypes, and the presentation can look like Duchenne. For the rest, sometimes go back to the table.
Thank you for that. And it prompts another question that I always wonder about. Do you have any theories about why such variability in the muscle groups that are involved? I mean, you just brought up dysferlinopathy, for instance, as something that can cause a very distal predominant myopathy. Others do not. Do we at this point now have an understanding, given the better genetics that we have on this and work going on in therapeutic development, which I want to get to in a minute, that provides any insight why certain muscle groups are more affected?
Very good question, Gordon. And I would say the first question that led me interested in muscle diseases, this happened probably back in 2000 when I just finished medical school, is why muscle disease tend to affect proximal muscles? I thought by now, 25 years later, we have the answer. I don't. I think we still don't know clearly why muscle disease, some affect proximal, some affect distal. But the hypothesis, and probably my personal hypothesis, is that maybe certain proteins may express more in certain muscles, and that may affect different phenotypes. But I mean, this furrin is a very good example that can confuse us because some patients present with distal weakness, some patients present with proximal weakness. That's by the same gene defect. And in this patient, when we look at the MRI in detail, actually, the pattern of fatty replacement in muscle are the same. Even patients who present clinically as a proximal or distal weakness, the imaging studies show the same finding. Bottom line, we don't know.
Yeah, who knew it could be so complex? Teerin, you brought up a really great point that I wanted to ask about, which is muscle MRI scan. Right, we're now seeing studies that are doing very broad MR imaging. Do you use muscle MRI very frequently in your clinical evaluation of these patients? And if so, how?
Maybe I don't use it as much as I could, but the most common scenario I use in this setting is when I have the genetic testing come back with the VUS. So we look at each VUS, each gene in detail, and if anything suspicious, what I do typically go back to the literature to see if that gene defect in particular has any common pattern of muscle involvement on the MRI. And if there is, I use MRI as one of the tools to try to see if I can escalate the pathogenicity of that VUS.
And a VUS is a variant of unknown significance for our listeners. I'm proud that I remember that as a geneticist. These are exciting times in neurology in general, but particularly in inherited muscle disease. And we're seeing a lot of therapeutic development, a lot going on in Duchenne now. What's the latest in terms of disease-modifying therapeutics and gene therapies in LGMD?
Yes, so there are several preclinical and early phase clinical trials for gene therapy for the common limb-girdle muscular dystrophies, for example, the sarcoglycanopathies. And they also have some biochemical therapy that's possible for the LGMD due to FKRPs. So there are many things that I expect probably will come into picture broader or later phase of clinical trials. And hopefully we have something to offer for the patients similar to patients with Duchenne muscular dystrophy.
What haven't we talked about? I mean, holy cow, there's so much in your article. What's one thing we haven't talked about that our listeners need to hear?
Good questions. So I think we cover all, but often we got patients with proximal weakness and high CK, and they all got labeled as limb-girdle muscular dystrophy. What I want to stress is that proximal weakness and high CK is a common feature for all muscle diseases. So they need to think broad, need to think about all possibilities, particularly don't want to miss something treatable. Chronic, slowly progressive cause, as I mentioned earlier, we think more about muscular dystrophy. But at the current knowledge, we know that rare patients with necrotizing autoimmune myopathy can present with limb-girdle weakness at a slowly progressive course. So make sure you think about these two in suspected LGMD patient that genetic testing come back inconclusive.
Well, that's very helpful. And fortunately, there are several other articles in this issue of Continue that help people think through this issue more broadly. Teerin, you certainly don't disappoint. I enjoyed listening to you about a month ago, and I enjoyed reading your article a great deal and enjoyed talking to you even more. Thank you very much.
Thank you very much, Gordon.
Again, today I've been interviewing Dr. Teerin Liewluck about his article on limb-girdle muscular dystrophy, which appears in the October 2025 Continuum issue on muscle and neuromuscular junction disorders. Please be sure to check out Continuum audio episodes for this and other issues, and thanks to our listeners for joining today.
This is Dr. Tishme Monteith, Associate Editor of Continuum Audio. If you've enjoyed this episode, you'll love the journal, which is full of in-depth and clinically relevant information important for neurology practitioners. Use the link in the episode notes to learn more and subscribe. AAN members, you can get CME for listening to this interview by completing the evaluation at continpub.com/audiocme. Thank you for listening to Continuum Audio.